The cause of death was listed as natural causes following a thorough external examination. But the medical examiner disagreed after analyzing the results from toxicological screening. A positive urine tox indicated the presence of multiple substances in lethal concentrations. The postmortem interval was estimated at 12 hours based on rigor mortis and livor mortis patterns. However, the physical evidence suggested this estimate was inaccurate due to a significant discrepancy between these findings and the time of death as reported by witnesses. Upon closer inspection, the medical examiner noted signs of acute intoxication that were inconsistent with the established postmortem interval. The presence of drug paraphernalia at the scene corroborated toxicological findings, indicating recent substance use shortly before death. This evidence pointed to an alternative timeline, leading to a reevaluation of initial assumptions and prompting further forensic investigation into environmental factors and potential cofactors contributing to the lethal outcome. Chapter: Case Background. The incident under examination occurred on October 15th in a residential apartment located in downtown Seattle. The deceased, a 34-year-old male resident, was discovered unresponsive by his roommate upon entering the living quarters at approximately 9:00 a.m. Initial observations indicated that the deceased was lying supine on the bedroom floor, surrounded by empty pill bottles and various drug paraphernalia, including syringes and small plastic bags containing white powders. The roommate immediately called emergency services, who arrived within minutes to assess the scene. Emergency responders found no signs of trauma or foul play, but noted a strong chemical odor emanating from inside the apartment. Medical personnel administered naloxone, suspecting an opioid overdose based on the observed drug paraphernalia and the deceased's unresponsive state. Despite resuscitation efforts, the medical team was unable to revive the individual, who was pronounced dead at the scene. The case was subsequently referred to forensic toxicology for further investigation into potential substance involvement. Chapter: Initial findings. Upon arrival at the scene, first responders noted a single individual, later identified for documentation purposes as the deceased, lying supine on the bedroom floor, unconscious and unresponsive to verbal stimuli or painful stimulus application. Despite resuscitation efforts, the medical team was unable to revive the individual, who was pronounced dead at the scene. The case was subsequently referred to forensic toxicology for further investigation into potential substance involvement. Immediate medical assessment revealed no respiratory effort or palpable carotid pulse. The scene conditions indicated a closed environment with no signs of forced entry, suggesting an indoor setting with limited external access points. Initial observations did not reveal any visible traumatic injuries, such as lacerations, contusions, or defensive wounds indicative of physical altercations. The body position and absence of apparent trauma led first responders to classify the initial manner of death as undetermined, pending further forensic investigation. Notably, the presence of an open bottle of prescription medication on a nearby nightstand triggered a suspicion of drug overdose, prompting the collection of urine samples for toxicological analysis. This sample provided positive results for multiple substances, initiating a comprehensive post-mortem examination to confirm and elaborate upon the initial findings. Chapter: Forensic investigation at the scene. Swabs from bodily orifices, blood samples from femoral vein, hair, and nail clippings were collected for toxicological analysis. Urine was obtained post-mortem via catheterization to test for drug metabolites. A complete inventory of medications and illicit substances found within reach of the deceased was documented and secured in tamper-evident bags. Personal effects, including a partially consumed bottle of prescription medication, suspected to be benzodiazepines, were bagged separately with corresponding evidence tags. The chain of custody log meticulously recorded each transfer of these items, maintaining integrity from collection to laboratory analysis. Notable was the absence of any recent alcohol consumption signs typically present in similar cases, suggesting an isolated drug ingestion event rather than a polydrug scenario. Laboratory analysis of the deceased included comprehensive toxicological screening to identify and quantify potential substances present at the time of death. Urine samples underwent immunoassay testing for a panel including benzodiazepines, opiates, cocaine, amphetamines, and cannabinoids. Quantitative confirmation was achieved through gas chromatography mass spectrometry, GCMS, with detection thresholds set at 5 ng/ml to ensure specificity and sensitivity in identifying drugs of abuse. Tissue samples from the liver, kidney, and brain were processed for histopathological examination, revealing hepatocellular necrosis indicative of drug-induced toxicity. Microscopic evaluation confirmed lipid vacuolization within hepatic cells, consistent with acute drug intoxication. Concentrations of morphine, 6-acetylmorphine, and codeine in urine samples measured at 450 ng/ml, 125 ng/ml, and 78 ng/ml respectively, surpassing established toxic levels for these substances. Forensic examination commenced with a comprehensive toxicological screening to determine the presence and levels of various substances in the deceased system. Urine analysis revealed positive results for multiple psychoactive drugs, including opioids and benzodiazepines. The postmortem interval was estimated based on body temperature decay and gastric emptying patterns, suggesting the time of death occurred approximately 12 hours prior to discovery. This timeline corroborated witness statements regarding the deceased's last known activities, but contradicted initial reports of a potential suicide note, as no such documents were found during the forensic examination. The sequencing of drug ingestion was inferred from the distribution and concentration of metabolites within various organs, indicating an acute overdose scenario rather than chronic use patterns. This timeline reconstruction provided critical context for understanding the sequence of events leading to the fatal outcome. The presence of multiple psychoactive substances in toxicological analysis indicates a complex intoxication scenario. The positive urine tox screen for benzodiazepines, opioids, and cocaine is significant, suggesting polydrug use contributed to the deceased's compromised state at time of death. Quantitative levels measured were consistent with potentially lethal concentrations, corroborated by toxicological standards. Pathology findings, including pulmonary edema and chemical pneumonitis, support respiratory impairment due to drug-induced depressant effects. The expert would testify that while substance presence is conclusive, precise causation requires interpretation based on additional clinical and autopsy data. This evidence supports the hypothesis of a fatal overdose, but does not definitively establish intent or manner of ingestion without further investigation into recent behavior and environmental factors. Chapter Resolution. The postmortem investigation concluded that the deceased had succumbed to a lethal drug overdose, as evidenced by the positive urine toxicology report indicating elevated levels of several psychoactive substances. The initial autopsy findings suggested an acute intoxication event, but did not specify the exact causative agents. Subsequent chemical analysis revealed benzodiazepines and opioids in concentrations exceeding therapeutic thresholds, consistent with a scenario of polysubstance abuse leading to respiratory depression and death. This finding clarified discrepancies observed during the preliminary examination, such as inconsistent signs of trauma or external pathology indicative of an accidental overdose rather than suicidal intent. The toxicological evidence provided definitive proof that the deceased's death was caused by acute intoxication from multiple substances commonly used for non-medical purposes. The findings allowed for a closure in understanding the circumstances surrounding the death and informed public health recommendations to address the broader issue of substance abuse within the community. This case underscores the critical importance of comprehensive toxicological screening in establishing cause and manner of death. Positive urine tox results necessitate a thorough review of substances present their concentrations, and correlation with clinical signs at autopsy. The file remains open,